Good morning, everybody, and welcome. On behalf of Essential Pharmaceuticals and Custodial HTK, we are so pleased to sponsor this morning session. Very pleased to be partners with Perfusion.com and the Sanibel Symposium. Terrific session yesterday, and we're looking to try and set the bar even higher today, which would be fantastic. I have the absolute privilege to present two renowned world leaders in myocardial preservation today, and also the unique ability today at our booth at 2 o'clock to have one-on-one time personally with these two terrific individuals. From 2 to 3, they'll be available for questions and answers today. And so without further ado, I'm going to announce our first speaker, who likely needs no introduction in the perfusion community. You probably saw his terrific talk yesterday on COVID, and he is the chair and clinical professor at Department of CV Surgery and Health Sciences in Ankara-Turkey. His contribution to cardiac surgery, including myocardial preservation, is unmatched. And if I had to list all of his publications, it would take the entire hour. You may have seen his latest publication in the American Journal of Cardiovascular Perfusion. And so his title today is Next Phase in Single Cardioplegia Techniques, Different Recipes Covering Every Type of Cardiac Surgery. Thank you, Dr. Gunaydin.
Thank you very much for this very kind introduction, and it's always my pleasure to be here. Of course, I prefer being really in Sanibel in person, but this year, unfortunately, I represent Sanibel meeting with the sunny weather in Ankara, which is not very much familiar. And today I'm going to talk about our latest research on single-dose cardioplegic techniques, because we're doing a lot of research before. And there's no conflicts of interest with any of the studies. So we are working in this hospital. We mentioned that before. So when we're talking about cardioplegia, single-dose cardioplegia, it's becoming more and more popular. When you check the PubMed, the publications are getting more and more every day, and mainly focusing on the liberal use of single-dose cardioplegic techniques in any type of operation. But of course, this is the paper in around 2015. And in that time, the most popular choice in adult surgery was the blood cardioplegia. But of course, as the time goes by, in the last 5-6 years, of course, the choices have all changed. So we have a Dalnido solution. This is the conventional formula that you all know much better than me. But of course, when we are talking about Dalnido solution, we're not talking about only one solution or one type of application. So we will discuss this later. And this is theoretically designed for pediatric use. And of course, now have more than maybe 300, 400 different modifications and way of application. And we all know very well the HTK Custodial. It's mainly based on sodium depletion of the extracellular space. So it has 3 different amino acids in the compound, and each has a different duty to perform. So there are not many publications to compare both these single-dose techniques. Usually the comparisons are made in between Dalnido or HTK separately versus blood cardioplegia or Plegisol or so. But mainly these two were designed for pediatric use, and for HTK, it was also used for transplantation. And there are only one single formula for HTK, but different modifications for Dalnido. So they really have very good satisfactory evidence in pediatric use. And now the evidence is gathering in adult or different types of surgeries. So in coronary artery bypass grafting, it's still on discussion how to use. I mean, they are used, but the methodology is being discussed. So hemodilution has always been a problem in the discussions, because you're delivering like 1,500 milliliters or 2 liters just once in the patients, causing some kind of hemodilution. So for Dalnido, lidocaine is a problem because there may be a kind of toxic level of lidocaine that may cause arrhythmia in the early postoperative period. For HTK, there are always dilemma about the sodium levels in the postoperative period. So, and there's still not very satisfactory data on the long-term outcome, and I will tell our experience. So, and there is a kind of cost difference in our country. I'm not sure about the US. So there are many different systematic review and meta-analysis on single-dose techniques, especially based on Dalnido. All of them just reviews, for example, in this case, they are reviewing more than 5,000 patients, adult patients, is a meta-analysis. And always the results are just very much similar. They are all non-inferiority results. They say, okay, this single-dose technique, Dalnido, for example, is not inferior to blood cardioplegia or plegisol, has some kind of advantages like short cross-clamp time, not always, and, for example, less defibrillation rate or something like that. That don't make any much very significant differences in the early post-operative period in the real practice. So that means they are very much comparable to the conventional techniques. They can be used in adult surgery. So all of those meta-analyses have nearly the same results. So early results, like this paper, for example, was suggesting to use those single-dose techniques in low-risk patients. But however, now I'm going to say just the opposite, to use them in high-risk patients. So as a conclusion of this literature review, we can say that they are always have equivalent or some better results in the early outcomes, but there are not any single paper on the long-term outcomes, like 1 year, 3 months, 6 months, or whatever. And how about the incidence of using these choices? So this paper also not very much new, that's 2015 or 16. So at that time, globally in the world, this single-dose techniques was not very much popular, but then in the last 5, 6 years, they have become popular. So in this paper, and in the case of US, so for CABG surgery, 4-to-1 blood or microplegia was the first choice. For valve or minimally invasive surgery, single-dose techniques. But for urgent operations, so custodial HTK was the first choice, according to this paper. So this Rumi is a philosopher from Middle East, and he says, everything about yesterday has gone with yesterday, and not today, it's needed to say new things. So that's why I'm going to cite our own research. So there are many questions regarding the single-dose techniques. Let's start with the questions. So which single dose for which patient? So we organized first an experimental study and presented it elsewhere in Heart Valve Society Surgery, but then published in JACT this year. So we have a cell culture. So in this cell culture, we have neonatal cells, adult cells, and myocardial cells. So we need to understand the topical impact of those cardioplegic techniques in the early phase and in the long term. So the design was like that. So these are myocardial cells, adult cells, and pediatric cells with respect to St. Thomas, blood, HTK, and Dalnido. These are very small wells, just containing about 1 milliliters of the solution on the cells. So we just have a baseline, and we checked for the long term, like 100 minutes, 2 hours, 6 hours, 24 hours, and 48 hours. And how they react with adult cells, pediatric cells. So, and we did a lot of testing, so there are technical details. So we did a microscopic staining, we did toxicity evaluation on these cells with respect to the solutions. So these are the early results. So these are fibromyoblasts, that means the heart cells itself. So in this sense, the HTK group has significantly better in the long term, but in the early phase, there were not any significant differences in between these 4 different cardioplegic techniques. In adult cardioplegic cells, again, in the early period, not many difference, but in the long term, HTK becomes more protective. And this is the pediatric cells. And in the long term, this time Dalnido plus HTK were significantly better than the control group, like plegisol or blood cardioplegia. So let's show that on the microscopic staining. So green cells means live cells, and the red cells mean dead cells. So this is myocardium itself. As you can see in the HTK group, the incidence of the green the intensity of green is much more better than any control, especially from St. Thomas in the long term. This is 24 hours, 48 hours, and even better from Del Nido in the long term. And this is for adult cells. So HDK, you see always green, and intensity is very bright. And Del Nido here, St. Thomas blood, they are all very much same. And in pediatric, both of them are not, it's much better than St. Thomas or blood, especially in the long term. And this is the toxicity test. And we understand that in the long term, St. Thomas and blood may be toxic to the cells, or let's say, not mainly toxic, but cannot handle cells to make them alive in the long term. So as a conclusion of this first study, we can say we just concluded that HDK and Del Nido are really effective in dealing with pediatric cells. And for adults, until, let's say, midterm results were very much comparable in between any groups, but in the long term, HDK was protecting better. And then we just come back to the OR from the lab and say, which single dose technique is better in the long-term protection? Because the missing data is the long-term evaluation, not in the short term. Because in short term, nearly none of the studies were demonstrating any significant differences. So we published this paper this year again in Asian Annals of Thoracic and Cardiovascular Surgery. And the idea was to follow up more than 300 high-risk patients within more than 2 years with a high STS risk score who underwent CABG surgery. So the first group was the Nido group, about 100 patients. Just the second group was HDK, and the third group was blood cardioplegia as a control group. And the idea was that we accept that these two cardioplegic techniques can go up to an ischemic time of 90 minutes, 1.5 hours. So this was our target for these two different combinations. And this time we check for the endothelial glycocalyx degradation in the cells. In the biopsies we just take from the heart. So as you know, glycocalyx is a membrane that just covers on the endothelium. It's this very specific structure in the cell. It's the first structure that's been broken in any case of ischemic insult. So this is the very early demonstrator of our ischemic insult or insufficient heart protection. But it's not the end. For the long-term from long-term follow-up, we just used a very specific follow-up monitorization for the patients. Whenever we just discharge patient from the hospital, we put on this long-term just monitorization and documentation. So we have specific people following up these patients. And these are just like a very much iPhone-like device, but with a button. So when the patient feels uncomfortable, they press on the button and they have an SMS message. So we call the patient to understand what's wrong with the patient. So, and then there's a continuous monitorization of ECG, blood pressure, and any other parameters. So we fix the parameters beforehand. We say bradycardia will be important, tachycardia will be important, of course AFib or angina will be important to show us the sufficiency of ventricular protection in the long term. And we compared these three groups in the early period. As expected, no difference significant in any of the parameters. And just interleukin levels were significantly higher in the coronary sinus blood of the Nido group. Syndecan is the marker of the glycocalyx, and syndecan levels were significantly higher in the Nido group. And this is long-term protection. We can say in the long term, we follow up those patients up to 1 month continuously. And the incidence of bradycardia, and we just check for everything. And as you can see, the atrial fibrillation was significantly more in the Nido group. And here you can see the total number of events. That means the patient press on the button, and rehospitalization rate were significantly more in the Nido group with respect to HDK, even with respect to blood cardioplegia as follow-up control group. So you can see from the graph the tachycardia incidence was significantly higher. AFib incidence was significantly higher in the anido group, and rehospitalization rate was significantly higher in the anido group with respect to blood and HDK group. So as a conclusion of this study, we say, okay, these two cardioplegic techniques work well, but should we really accept 90 minutes for the anido safe? Because for HDK it was safe, but for the anido, 1.5 hours may be long, not to cover every type of myocardial protection. So this was the question raised at the end of this study. And then we go up one step further to give a kind of response about the hemodilution, because as I've told you, hemodilution was one of the main concerns because you're delivering a lot of volume in a very short time to those patients. So there are publications demonstrating the hemodilution levels for those single dose techniques. And again, we compared 4 different groups with really a significant number of patients in 4 years. And the endpoint was the incidence of transfusion, and secondary endpoint was the hematocrit change during any time of the surgery. But our strategy is clear. Whenever we are using single dose techniques, we always use ultrafiltration. And in this study, we just apply ultrafiltration for every patient. So the idea was to use ultrafiltration until we reach the hematocrit level 25% before we're going off bypass. And this is the early results, no significant difference, as always we expected. And this is the hematocrit levels. So if we use ultrafiltration in the single dose techniques, we never have significant hemodilution in any time of the surgery with respect to control groups. So we always suggest to use ultrafiltration with single dose techniques in any type of operation at the end of this conclusion. And then when we have problems with the 90 minutes for the anido, we just try to understand if redosing will make any difference in single dose techniques. So this paper was published this year in Innovations Journal. So we compared again 2 different groups with them, the anido and HDK, in 100 patients. But if any of these patients received an additional dose, we just formed the subgroups for these 2 groups. And this is a very messy, maybe, to exclude or include the patients. But finally, we also studied aquaporins here. So we started with 100 patients, again with the target of 90 minutes. So no difference before the operation. And you can see with some kind of exclusions, we have 95 patients in the anido group, 96 in HDK group. This is minimally invasive aortic valve surgery. And if they receive an additional dose, we just form subgroups. So this is the anido redosing and HDK redosing in 30 patients each group. So with these patients up to 90 minutes don't receive any additional dose, not any significant difference in between these 2 techniques. But when they receive additional dose, then the anido group really becomes unstable, probably on the lidocaine dose or lidocaine toxic levels. So we see significant differences in AFib in the postoperative period, AV block, and expectedly the ICU stay was longer than the HDK group. So this is also an important question to this redosing should be very, very well decided before, especially in the anido choice. And interleukin levels in the redosing group was significantly higher in the anido group. Maybe inflammation causes arrhythmia. And again, the very sensitive parameters, syndican levels, showing us the glycocalyx degradation, was significantly higher in the anido redosing group. And this is the aquaporin levels. Aquaporin are the membranes or the molecules inside the cell dealing with the volume overdose. So if the aquaporin level is not satisfactory, so cell cannot handle the additional volume. So that means they're producing more and more aquaporins to deal with the additional volume in the anido group. So this is the pictures. The anido with the additional dose and HDK with the additional dose, not very much different in between those groups. And here you see aquaporin levels, that is how to handle the volume overload in the cells. So this is the 90-minute and plus the additional dose. So you can see really the edema inside the cell clearly. An HTK additional dose, not very much edematic cells in the HTK group. So as a conclusion of this study, we said 90 minutes is too long for, especially for Delnido, and redosing is not, is not a very good choice because it may have many concerns in the long term. So that was not our only idea. When we check the literature later, that we see the discussions going on. For example, single dose cardioplegia, how long is too long? And people started to discuss 60 minutes redosing, 30 minutes, 45 minutes. I have seen many papers discussing to redose in every 45 minutes, in every 60 minutes or so. So people understand 90 minutes was not safe, especially for Delnido. And we see some different combinations like Delnido with a hot shot. I also see many of my colleagues using this technique. So the idea was to use the hot shot to clear, especially lidocaine inside the cells when we're coming off, when we're declumping the aorta. Or again, the discussions were going on to use this single dose techniques in any type of surgery because the initial idea was to use that in long-term ischemic times, like up to 1.5 hours. How about 2-vessel CABG, 3-vessel CABG that has a cross-clamp time about 60 minutes. So shall we use this or not? So considering all this, we designed a new study, and the study was just completed recently in the last month. So the idea was to include again 3 different groups with 100 patients in each group, Delnido, HTK, and blood cardioplegia. But this time, our strategy was different. So for Delnido, we just lowered the dose. That means we give only 1 liter for patients as a single dose to cover 1 hour. Again, in HTK, 1 liter to cover 1 hour, and blood cardioplegia is always the same protocol, so every 20 minutes. So our idea was to understand if it was feasible to use lower doses to cover less ischemic times, because the idea in the beginning was to cover 1.5 hours, but this time we don't want 1.5 hours. We only want 1 hour for a routine, simple surgery like CABG plus 2, CABG plus 3, or whatever. So we lowered the doses to overcome any hemodilution concerns, plus we want to make sure that it works for 1 liter for 1 hour in any of these groups. So again, before the surgery, there was not any significant difference in between these groups. And in post-operative period, we don't see any significant differences. Only, of course, volume overload in the blood cardioplegia group because they received 3 different doses in every 20 minutes. So these 2 has only 1 liter for 1 hour, and it worked very well for even Delnido or HTK. So at the end of this study, we are still working on this study to finish, and we'll probably publish late in a short time. We can say, okay, you can use 1 liter HTK to cover 60 minutes of ischemic time so that you can deal with, let's say, 70% of all operations. So you can use 2 liters of HTK to cover minimally invasive surgery or anything longer than that. That's just same story for Delnido. So I'll just start to give my own impression of my personal experience. So temperature and pressure is very important when you're using single dose. Most people are not giving, let's say, sufficient attention on these 2 parameters, temperature or pressure. Duration of infusion is important because in order to reach the intercellular levels, you have to use, you have to wait as a surgeon for 5 minutes, 6 minutes, or whatever. So for any valve surgery or including coronary artery bypass surgery, I always do venting because there's a volume overload. I use venting to just take this extra volume so to overcome hemodilution. I also use ultrafiltration in any single dose case. I never needed to do anything to correct the sodium levels. I never experienced that if I use ultrafiltration and venting, of course. If I need to use a redosing of Delnido, I always use the half dose of lidocaine in the second repeating dose, because I'm always afraid of lidocaine toxicity to cause arrhythmia or atrial fibrillation in the early postoperative period. So for Dalnido, of course, there are many formulations. It's not easy to speak on only one formula, so it's not easy. So I just give my own ideas on redosing problems. So for 60 minutes, we showed that it was feasible to use 1 liter. So my own strategy, if I have a simple case with good function, ventricular function and cross-clamp time expected to be lower than 1 hour, you can use anything, including blood cardioplegia or whatever. What do you have? For simple cases, poor left ventricular function, cross-clamp time lower than 1 hour, now I change. I used to use blood cardioplegia for this before, but I know now you started to use custodial HTK only 1 liter for those patients. For combined cases like wild plus cabbage, good left ventricular function, cross-clamp time over 1 hour, I still try to use Castido if I have, or not. If it's a good left ventricular function, I can also use Dalnido here. For combined cases, cross-clamp time longer, poor left ventricular function, emergency case, so minimally invasive surgery, I use Castido HTK if I have. So in COVID, of course, we discussed yesterday evening, but we have to change our strategies regarding the patients. So in the COVID era, I accept all the patients as high-risk patients. So I don't need any additional time to spend to prepare cardioplegia or whatever. So I usually choose Castido HTK since it's already there. I don't need to wait or worry about anything. So it's a very good alternative. If I don't have that, I'm not sure about Dalnido because it's a crystalline solution. And in that case, I will choose a blood cardioplegia. So as the conclusion, myocardial preservation is the concept without clear and specific single signs. And this is the point of discussion that's going on since the last, let's say, 30, 35 years. But long-term outcome have not been studied, but because it's very difficult to document the long-term outcomes. You have to use monitoring device. It's not comfortable for the patient, but we have to have some data or evidence to talk about the long-term outcomes. So our data in comparing the patients up to 1 month may give some kind of idea, at least to start the discussions. So we are still trying different formulas to cover every type of surgery. And I believe we are in a good way because we can cover now, let's say 90% of all operations with single dose techniques using different combinations like 1 liter, 2 liters, or whatever is the question. So we are always discussing the patient specifically with our perfusionist beforehand. So we decide any type of strategy we use, and then we use on the next day. Thank you very much.